Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to take some time to speak through why, despite what was said at the beginning of the profession of osteopathy with respect to anatomy being absolutely central and essential, and the first lesson, the last lesson, may I ever have more anatomy, right? So doctors still talking about the importance of anatomy. Now, anatomy is obviously important, but it may not necessarily be as important as some people think that it is, or provide the value to a practitioner that somebody thinks that it could. So the underlying assumption of a deep knowledge of anatomy for a hands-on manual practitioner is that they can meaningfully interface with all those layers of anatomy. In a very unfortunate way, we are aware that aside from very, very obvious structures, it's actually really hard to interface with deeper layers of anatomy. So personal pet peeves of mine are things like the QL, or the quadratus lumborum, and the psoas. All problems, obviously, in the low back are from the QL and from the psoas. Kidney problems are from the psoas. The psoas does this, the psoas does that. The QL, you can definitely palpate the QL. You can palpate the psoas. You can do all these things. No, you can't. If you want to palpate the QL, you have to be heavily in front of the erector mass. The person has to be likely in prone, because if they're sitting up, you won't be able to have access, or maybe in lateral. But you have to go in front of a bunch of tissue. And really what you're doing is you are deforming the posterior abdominal wall to be able to palpate that lateral to the psoas. If you want to palpate the psoas, you have to go, the claim would be you go medial to PSIS and then you go posterior. So you're definitely going to feel iliacus, and then you're going to be able to palpate the psoas at that point because it's relatively superficial. It's not. It's going to be covered by abdominal tissue. It's going to be covered by the colon, the small intestine. You're not palpating it, right? Palpating SPs specifically, right? So knowing exactly which SP you're on assumes that a person has a normal, maybe not a normal, but a common amount of vertebrae, a common amount of spinous processes. If you're palpating SPs in the lumbar column, you literally don't know, unless you have an image, whether somebody has 4, 5, or 6 lumbar vertebrae. Now, odds are they have 5, but they may have 4, they may have 6. If you're palpating ribs, you don't know if a person has 12, 13, or 14 ribs, because they could have supernumerary ribs on the top and the bottom. You don't know. Odds are they have 12. If you're palpating the abdomen and you say that you're palpating organs, if you can clearly palpate an organ in a patient, there's something going on that is inappropriate for you to interface with. It is much more likely closer to a medical emergency. So one of the things that I end up saying is, if you can palpate a liver, the answer is hospital, right? Obviously, there's certain areas where things are more clear. They're large structures. There's really not a ton else going on. If we're talking about being able to palpate the mandible in relation to the temporal bone, the TMJ, yeah, okay, well, yeah, you can palpate that joint line. You can see what's going on with motion. But when we start to come over here into the muscles of mastication, to be able to say absolutely 100%, the only thing that I'm feeling is a pterygoid, well, you got to go in the mouth. You shouldn't go in the mouth. But even then, you may be feeling other things. You've got macinator, buccinator, masseter, not macinator, masseter and buccinator. Like, you've got a bunch of muscles here and a bunch of adipose tissue. You've got a lot of stuff going on here that it's going to make it harder to piece apart which one is doing what. Whereas if you treat it like a general unit, then you know that the fiber direction is relatively vertical, not perfectly vertical, but relatively vertical, and you can work perpendicular to fiber direction. When you start to get into talking about palpating transverse processes, if you can palpate transverse processes, something is exceptionally wrong with a person, like exceptionally wrong. They have probably become so emaciated that their muscles are not robust enough to hide their transverse processes. So if you feel a transverse process, or you think you do, you're probably wrong. If you can, then that person is probably closer to the need of emergent care because they're so emaciated. If you're talking about things like ribs, right, and you want to talk about certain pieces of ribs, Some portion of ribs will be more exposed, some portion of ribs will be less exposed. You can't palpate a rib head, right? You just can't. It's in front of the transverse process. If you can palpate a rib head, that person's wide open and should go to the hospital. The reason that I point to some of these examples relatively superficially is that, again, the underlying assumption of knowing anatomy deeply is that you can clearly do something superficial and relate it to the deep anatomy. Now, in your head, you can, but to be able to actually do that and know that you did it relies on the person on the table, the person in front of you, the person presenting for some kind of osteopathic interface is built the way you think they're built inside. So you have a lot of layers of assumption. You're assuming that they're relatively close to what you know from books. Depending on the book, depending on the cadaver specimens that you've seen, depending on your previous knowledge, you may either acknowledge that anatomy is relatively stable, but within that relatively stable pattern, it is highly variable between individuals. Once you get deep to the skin, things change a lot from your assumption. And you know that if you've checked a lot of anatomy, especially through either images, through a wide variety of textbooks, through a wide variety of surgical intervention, which if you're an osteopathic practitioner, hands-on practitioner, anywhere other than America, you're probably nowhere near surgery. Doesn't mean you aren't, but you're less likely to have seen inside of a living person, or the amount of cadaver dissection you've done. If you're an osteopathic manual practitioner, it is very much less likely that you've done a lot of cadaver work. It doesn't mean you haven't. It just means you're less likely to. The vast majority of osteopathic practitioners have not done a ton of cadaver work, so they're less likely to know that anatomy, while relatively stable, the blueprint is relatively stable, it is highly variable between people, such that if you do something superficially and believe that it means that you're doing a specific thing where you can neither see, feel, or hear, you're making assumptions that are very, very easy to be wrong. So this allows us to fundamentally make the argument that the thing that is more important in the actual interface between practitioner and patient, or practitioner and client, whatever terms you prefer, the thing that is likely more important as a behavior is the ability to identify motion restrictions that can be agreed upon by many people that would observe. So people would see the same things and agree that they're seeing the same things, or feeling the same things, or hearing the same things. And then behaving in a way that makes some change to that without the patient saying, ouch, using the barrier of concept appropriately so that you don't generate protective responses. So the actual application of osteopathic treatment relies in behavior and in observation less on being clear on the exact structure that you are on, and more so clear that you have appropriately identified motion restriction. Now that motion restriction is either a gross motion, right, the arm going straight up, or it is yield to pressure of soft tissue. So this tissue either squishes or it doesn't squish. Now it can squish perpendicular to fiber direction. You can grab it and you can slide it over a still bone, or you can keep the bone still and literally just squish into the tissue, depending on the circumstance and the angles and how things are available to you to palpate as a practitioner. It either squishes or it doesn't squish. That is where treatment will be applied, not the specific layer of the specific structure that you know you're right about, but you can't know you're right about because it is deep. So you have to make a large amount of assumptions, which allows you to have way more opportunity to be wrong about what you're doing, but think that you're right. Whereas what I'm suggesting is if we focus more on the actual applied behavior and the ability to figure out where to apply the behavior, which is appropriate motion testing, identifying appropriate motion restriction, and interfacing with it in a way that restores motion to some degree and also doesn't rely on you knowing for sure, air quotes, for sure, that you're on a specific structure. It relies more on your ability to not make them say ouch, not generate protective responses. So the reliance on anatomy is probably less of a useful tool than many people think it is. People probably think it's an exceptionally useful tool because there has been a heavy reliance on teaching anatomy in their osteopathic education, in their osteopathic career, on interpreting through anatomy, so top-down interpretation as opposed to bottom-up identification of motion restriction. So they think more about where they're going to go as opposed to attend more to where it's restricted. Now, it doesn't mean that everybody does this, because for the most part, I do make the argument that osteopathic work is generally good, but the stories are crazy. So my suggestion would be that most people are probably identifying motion restriction reasonably well. They're just over-relying and over-interpreting what's happening, because you can have multiple people find the same motion restriction and call it different things and interpret it differently because of the previous experiences and previous pieces of information that they have. They're thinking with previous details, which is exactly what everybody does. Which is why my suggestion is to zoom back from the specific details, zoom into the identification of motion restriction appropriately and honestly. It's either moving or it's not moving. And you have taken the appropriate steps to make sure that the thing that you're saying is not moving is the thing that you're attempting to move. So for some of you who are only listening, but for the rest of you who can see this, if I turn the head left, right, and then the torso turns with it, and I talk about really good left rotation of the neck, right, if I'm applying a test to somebody saying that, so I turn the neck left and then I allow the torso to turn with it, and I say left rotation of the neck is good, then I haven't done my due diligence. Relational motion is the concept that allows us to both assess and treat much more meaningfully and accurately, such that I need a still torso in order to be able to make any claim about how the neck and head move in relation to that still torso. If I allow the torso to move, then I'm not testing the neck anymore. Just like if I want to test the hip, the pelvis needs to be still and the hip needs to move, right? It's just that simple. If I want to say something about any structure, I need something to stay still in relation to it so that I get appropriate understanding of that motion characteristic. So it's about making sure that your test is valid, that your interpretation is the motion that is restricted or the motion that is free, and not over-interpreting and saying that must mean that this blood vessel, that this lymphatic node, that this fascia, that this muscle specifically, aside from exceptionally obvious muscles, that this ligament, that this blah, blah, blah on down the line is definitely the problem. That's over-interpretation based on large amounts of assumption. Whereas if you zoom back, and I've said this many times, if you keep your attention on the motion and you talk about the motion, you are probably more accurate than if you think anything deeper than the restricted motion. So if you stick to motion, you will probably be accurate in your interpretation and accurate in however you choose to interface with the person that you found that restricted motion in. Whereas if you start to go deeper and interpret what the motion restriction means based on specific tissues, you have a much stronger likelihood of being incorrect, of making more errors that you don't know that you're making. So it doesn't mean that people don't need to know anatomy. It means that there may be an over-reliance on anatomy with respect to how they're approaching their choices. They're choosing based on what they think with respect to anatomy as opposed to what they've observed with respect to restricted motion. So anatomy matters. You have to know it to have some idea of what the heck to expect, what the heck could be going on, especially if something is very, very, very wrong and you know that it's going to be inappropriate for you to interface with by moving it, because moving it would be a red flag or a contraindication because it may be broken, it may be torn. You can say, hey, you may want to consider this. It allows you to understand sometimes the mixing of what somebody's complaining about and what you're finding, such that you could maybe point in a general direction and say, you know what, it seems a lot like it could be here. And there are more obvious things, right? So like a biceps tendonitis is a little bit more obvious than, say, a specific ligament in the hip, right? Something like that. So we want to be really careful with how we speak about anatomy to one another, especially when we're trying to teach people how to do other things. If we just focus on the motions that we observe that are restricted, we'll make good choices in how we interface with it. If we're thinking about specific tissues and we have an idea of how we're supposed to interface with those tissues, we could miss it. So being organized in how you're attempting to apply treatment means that you test a variety of activating forces and a variety of holds and a variety of movements to find the one that the person responds to the best. Whereas if you just think that you found a certain thing and it means it's this tissue, it means it's this structure, it means it's this nerve, it means it's this whatever, then you're going to act as if that's what you do. So if it doesn't work, you don't know what to do. Whereas if it's about the motion and you have a set of tools to choose from with respect to the motion, probably more accurate. You're probably going to have a more generally positive range of outcomes or a more stable, reliable set of results in a positive direction than if you just think that everything's fascia, that if you think that everything is nerves, that if you think everything is fluid, if you think everything is this, that, or the other. So your interpretation of specific anatomy is where it's very easy to make errors, because when you think anything other than the movement, you are more likely to make assumptions. So again, anatomy matters, but it probably doesn't matter the way that people think it does, because they never examined the assumptions that must be correct for you to be able to interpret accurately with respect to a motion restriction and what anatomy it specifically means is restricted, especially on a deeper level. If you just stick with the gross motions or the smaller motions, squishy, not squishy, so you look at a soft tissue, squishes or it doesn't squish, and a joint either moves in the direction you tried to move it or it doesn't, then that's as far as you really need to go in application and interpretation when you're actually working. That said, specific disruptions to specific anatomy tells you what not to do as opposed to what to do. So contraindications and red flags are important. So imagery, so say MRI, say X-rays, whatever image that somebody is able to provide you with so the patient is able to bring the practitioner that information. It doesn't tell you what to do, it tells you what not to do. The images identify danger as opposed to identifying safety for the hands-on manual practitioner. So if something is broken or torn, you don't move it. If something is not broken or torn, well, now you know, right? You can probably move it with a higher degree of confidence that everything's going to be safe. So again, probably over-reliance through over-interpretation of anatomy based on identified motion restriction, whereas if you just stick with the motion restriction, you're probably going to be more accurate to the circumstance. So hopefully that allows you to follow a lot of, again, the way that I approach this, thinking more about motion than the specific anatomy. And the rationale for that is that you have to make a lot of assumptions to be accurate about the anatomy, such that, let's just say you do good work on the motion and you interpret the anatomy and you don't know that you made the error in the interpretation of the anatomy. Through experienced utility, you'll be convinced that you were right, not knowing that it's really easy for you to be wrong all the time and still get the positive result. So hopefully you learned something from that. Thank you for listening, and we'll talk again soon.